Welcome to Easy Medicine. If you're preparing for step 1 or just want to master high-yield cardiology concepts in a simple and practical way, this video is for you. Today, we're going to break down 6 high-yield clinical cases that will help you understand how cardiology concepts actually show up in real exam questions and real clinical scenarios. From athlete's heart to congenital conditions to heart sounds, pharmacology, myocardial infarction localization, and structural complications. This is not just memorization. This is understanding. Let's get started. This 32-year-old woman comes to the office for a preconception medical evaluation. She feels well, reports no health issues, and has had regular menstruation. She is a long-distance swimmer who recently retired from a 10-year professional career, but she continues to train regularly. She does not use tobacco, alcohol, or illicit drugs. Vital signs and physical examination are normal. In this case, we compare her with a person of similar age and sex who has a sedentary lifestyle. The question is, what cardiac changes are most likely present in this patient? The correct answer is unchanged left ventricular ejection fraction, increased left ventricular cavity size, and increased maximum cardiac output. At rest, cardiac output is approximately 5 liters per minute. During exercise, it commonly increases to 15 to 20 liters per minute. However, in highly trained endurance athletes, cardiac output can reach up to 35 to 40 liters per minute. Maximum heart rate does not significantly increase in these athletes. Therefore, the increase in cardiac output is mainly due to an increase in stroke volume. Remember, cardiac output equals stroke volume multiplied by heart rate. To meet the metabolic demands of endurance training, the body increases red blood cell mass and plasma volume, improving oxygen delivery. Skeletal muscles also develop increased capillary density, which enhances oxygen extraction and reduces systemic vascular resistance. This combination increases venous return, placing a higher volume load on the left ventricle. As a result, the left ventricle undergoes eccentric hypertrophy, increasing its cavity size and improving diastolic filling. This increased end diastolic volume is the main driver of the elevated stroke volume seen in endurance athletes. Case 2. A 1-day-old infant in the newborn nursery is found to have a harsh, hollow systolic murmur. He was born at 39 weeks to a 36-year-old mother who deferred prenatal screening. There is no family history of genetic disorders. Vital signs are normal. Physical examination reveals a flat facial profile, protruding tongue, and small ears. The question is, what most likely occurred prior to conception? The correct answer is meiotic non-disjunction. During normal meiosis, homologous chromosomes separate properly. In non-disjunction, chromosomes fail to separate, resulting in gametes with an abnormal number of chromosomes. Advanced maternal age, especially over 35, increases the risk due to factors such as oxidative stress, depletion of oocytes, and telomere shortening. The most common outcomes of maternal non-disjunction are trisomy 21, trisomy 18, and trisomy 13, in that order. Less than 5% of Down syndrome cases are due to Robertsonian translocation, typically involving chromosomes 14 and 21. Classic features of Down syndrome include flat facial profile, epicanthic folds, upslanting palpebral fissures, protruding tongue, and small ears. Congenital heart defects are present in about 50% of cases, including atrioventricular septal defects, ventricular septal defects, and atrial septal defects. Case 3. This 64-year-old man presents with chest discomfort and mild shortness of breath that began 1 hour ago after emotional stress. He has a history of hypertension and diabetes. His blood pressure is 180/100 mmHg, and heart rate is 100 beats per minute. Electrocardiogram shows no acute ischemia. On cardiac auscultation, in the left lateral decubitus position, and during full expiration, a presystolic sound is heard. The correct answer is left ventricular hypertrophy. This sound corresponds to an S4 heart sound. It occurs in late diastole, just before S1, and is caused by atrial contraction forcing blood into a stiff, non-compliant left ventricle. This generates vibration due to rapid deceleration of blood or impact against the ventricular wall. S4 is commonly associated with diastolic dysfunction and left ventricular hypertrophy, most often due to chronic hypertension. Case 4. A 45-year-old man presents with progressive shortness of breath and fatigue over 2 weeks. He has a history of non-ischemic cardiomyopathy and poor adherence to treatment. Blood pressure is 106/58 mmHg, and heart rate is 88 beats per minute. He has difficulty lying flat. Physical examination shows elevated jugular venous pressure, bibasilar crackles, an S3 heart sound, and bilateral lower extremity edema. Milrinone infusion is started. The question is, what is the most likely effect of this therapy? The correct answer is vasodilation. Milrinone is a phosphodiesterase 3 inhibitor. It increases intracellular cyclic AMP levels. In cardiomyocytes, this increases calcium influx, improving contractility. In vascular smooth muscle, it promotes calcium reuptake into the sarcoplasmic reticulum, leading to muscle relaxation and vasodilation. Venous vasodilation decreases preload. Arterial vasodilation decreases afterload. Together, these effects reduce cardiac workload. Although hypotension may occur, it is often offset by improved cardiac output. Case 5. A 51-year-old man presents with chest discomfort, dizziness, shortness of breath, and nausea that started 30 minutes ago while shoveling snow. He has hypertension and type 2 diabetes. Electrocardiogram shows ST elevation in leads I and AVL. Cardiac enzymes are elevated. The question is, which artery is most likely occluded? The correct answer is the left circumflex artery. ST elevation indicates acute myocardial infarction. Leads I and AVL correspond to the lateral wall of the left ventricle. Leads V5 and V6 may also show changes in lateral infarctions. The lateral wall is supplied by the left circumflex artery, which originates from the left main coronary artery. Case 6. A 35-year-old woman presents with progressive dysphagia to solid foods. She feels that food gets stuck in the mid-thorax. She also has palpitations and dyspnea on exertion. She has a history of rheumatic heart disease treated in India. A barium esophagram shows extrinsic compression of the mid-esophagus. The correct answer is left atrial enlargement. Rheumatic heart disease commonly leads to mitral stenosis and regurgitation. This causes increased left atrial pressure and progressive enlargement. The left atrium lies directly posterior to the esophagus. Enlargement can compress the esophagus, causing dysphagia, known as cardiovascular dysphagia. In some cases, it can also compress the left recurrent laryngeal nerve, leading to hoarseness and chronic cough. If this video helped you understand cardiology in a simpler and more practical way, make sure to subscribe and stay connected with Easy Medicine. This channel is designed to help you review high-yield medical concepts anytime, anywhere, whether you're studying, driving, or just reinforcing what you already know. And if you want to keep building momentum, go watch the next video in this series, where we continue breaking down complex topics into simple, high-yield concepts. See you in the next one.